So let's see if we are online. Yes. First question, find the heart. Sorry? Yeah.
Because of all the color settings in it. Let me change right from left again.
Julini, do you have
Yes?
microphone or no?
Is it live there already? I can't
Yeah.
see. Right, so thank you, Rabbi, for asking me to do this. This lady is about 29 weeks, and we're just trying to, so head is down, cephalic, that's the first step. I'm going to widen this set a little bit more because she is, can you see, does it project well there?
Yes, it's well.
Right, so we don't have the fetus in the best position, but actually it's quite good because quite often, if the spine is anterior, you can get an ultrasound window coming through here, through the ribs. And this view is quite good, actually, for seeing all the heart structures. So I'm going to start by checking laterally. You should have worked that out because this baby's got head down. So this is the, sorry, pressing the wrong button, the
What you want?
arrow?
Yeah,
This is the left side of the baby. So we have the, sorry, I'm not familiar with this.
What do you want to do? Just
Machine.
tell me.
So the stomach is on the left side, the aorta is to the left, and the IVC is to the right. So that's a very straightforward view of the abdominal side. So that basically means that in the chest, I'm going to zoom. Maybe you can do it for me. In the chest, we have this is the left side. The heart is on the left. The apex to the left. The axis is 45 degrees, so the anteroposterior line. The site has been normal, like that. It just means that the atrium on the right here is the right atrium, and the atrium on the left is the left atrium, which is as it should be. And then we, following the cardiac guidelines, we would do a 4-chamber view structures, starting from the entrance here of the pulmonary veins. We can see one coming here. Just need to adjust a little bit to get rid of the shadowing. One coming from the right lung. The flap valve of the foramen ovale. The foramen ovale itself is wide open. We see 2 valves with the normal offset. We see the moderator band coming across the right ventricle and a smooth apical portion of the left ventricle. Valves are open and close normally. And then a very slight tilt of the transducer, and I stop here. We're having some spontaneous contrast. That's because the equipment these days is so good resolution that you, even if you don't want to see, it's actually a bit distracting sometimes. I don't necessarily need to see so maybe we drop the frequency a little bit, see if we can get rid of that, not too much. Probably be better as it was. We just have to cope with that, but most machines now are giving this spontaneous contrast, which sometimes we don't want to see because I want to see the valves. So in this view, which is a left ventricular outflow tract, it's nice to see the continuity here between the septum and the anterior wall of the aorta with the aortic valve review. So I just wanted to freeze and then go back to see the aortic valve closed in here. And then it opens and it closes, maybe a bit more again. Open and close, open and close, so that's a normal valve. And then a bit more tilting towards the right ventricular outflow tract. There we have our right ventricle in here, pulmonary valve, main pulmonary artery, and the aorta that was coming from there forming the three-vessel, the middle vessel in the three-vessel view, the SVC to the right. There's the thymus, we're already there, quite nicely shown. Different contrast from the lungs. And that's the aortic arch with the trachea just here. So that, from the screening point of view, is all really that one needs to do to demonstrate a normal heart. But if I was scanning this lady, so very quickly you would see that this heart is normal. I'm going to put color, because I would always do normal, any color there. Maybe we'll drop the frequency a little bit, because she's 29 weeks. So I'm going to drop the frequency of the transducer just to get more color information. And I quite like to split the image into, this equipment at Toshiba is a twin image as shown, because if you're not used to color, you can see the image with and without, and at the same time try and correlate the two of them. So shall we try the normal color? I like to use both colors because I like to know the velocity across the vessels. That picks up minor abnormalities because of aliasing. So we have here picking up more the feeling of the right ventricle rather than the left ventricle, because the left ventricle we're already picking up some of the outflow tract. Velocity range.
This one.
Yeah. We need to increase this here because 40 centimeters per second was a bit low. So normal color velocity across the aorta. So how do we know that's normal colors? Because we have a scale over here. So very quickly you can see that that shade of blue is well within the range. So the velocity across the aortic valve in that angle is less than 70 centimeters per second, which is perfectly normal. So very quickly you know that there is no aortic stenosis, even if you did not see the aortic valve properly. Then tilting up towards the pulmonary outflow tract, we just see the crossover here. See a little bit of the blue. If people like to use the crossover, a little bit of the blue coming off the aorta and a bit of the red coming up through the pulmonary artery. And I'm going to drop the velocity a little bit to try and demonstrate the branch pulmonary arteries. You can see them without the color. That's the right pulmonary artery just starting here and the left. Maybe we go to the high definition flow now. And I'm going to drop the velocity to come back
It's the frequency.
Velocity, just to demonstrate the pulmonary veins, increase the gain a little bit. So that's quite nice. So in there, baby starting to breathe, and then that influences the pulmonary venous flow. So you can see how nicely you see all the pulmonary veins coming from the left lung and from the right lung into the left atrium. And for the pulmonary veins in particular, I like to have this split image because that I showed to you. You can have veins coming towards the left atrium here, but actually if you have anomalous venous drainage, they come towards here and then they disappear somewhere else. So if you have a twin image, you can see that actually those veins are really coming into the atrium of the normal communication. So your descending aorta. In this view here, you can see that the sensitivity is so good that we are picking up the normal azygos vein here, just behind the aorta. See it flow in a different direction from the descending aorta. And I quite like to use the power or high definition to go back to the ventricular septum. Scale. To look at the ventricular septum, we're having a little bit of noise there. I need to clear that. So it highlights, by filling the ventricles, it highlights the ventricular septum more clearly. Going all the way to the apex, and then I drop the velocity a bit more Be careful not to drop it too much because we start getting artifacts. Then we move towards the outflow tracts again. That's our aorta quite nicely, and then the pulmonary artery just starting to come. You see, the pulmonary artery really, it trifurcates, and before we come to the level of the three-vessel trachea view, which is where we are, just below that level. Oops, sorry, I dropped the microphone. Just below that level, we can see the branch pulmonary arteries, and in here we are seeing, this is the left lung, so this is the main pulmonary artery, the left pulmonary artery here going to the left lung. The right will come this way. It's not picking up the color in this particular plane, so we need to look for it. Maybe a bit higher. No, again. Might have just to rotate this. So we'll come back to the right pulmonary artery because I'm not quite picking up the color through there. So from this view, it's quite a nice position to, just from there, we can see the arch views and everything else. It's very easy to rotate the probe. And from here, just rotating to a cross-section through the ventricles. And you see a short axis here through the mitral valve. And that comes actually quite pertinent to my talk afterwards because we see a normal mitral valve, which is a bileaflet structure. So you can see it opening. It opens like a fish mouth, close, and open, and close, because that is a key thing sometimes if you want to differentiate from an AV septal defect. So we have the short axis through the valves going to the papillary muscles of the left ventricle. There are two of them, nicely placed here. The right ventricular outflow tract. And then a little bit of tilting, we should get the aortic valve in here, in the cross-section, pulmonary valve. And I need to adjust to try and get my aortic arch. So in here we see the left atrium behind, the right atrium in the front, and the aorta in the middle, wedged between the two ventricles. That's the aortic valve. And then coming up the ascending aorta, the first head and neck vessels, the transverse aortic arch, and going down to the descending aorta. So this is the innominate vein coming here, the one that Rabbi is talking about, or he's going to talk about the brachiocephalic vein seen on the sagittal plane. This is coming from the head. So there are lots of things you can see from all sorts of planes. Maybe I'll take the opportunity. And those are the pulmonary arteries when I wasn't looking for them. They're nice and clear. Okay, there we are. It's just, you see how important it is to freeze the image. Remember about the car going very fast? Once you see it there, you come back, and that's the left pulmonary artery and the right pulmonary artery. And then just a little bit higher from that, you have your arterial duct, and then the transverse aortic arch. And then if we can follow the transverse arch from there, we can do just a rotation here to get the whole arch. Maybe I'll do a twin vision. So in here we have the brachiocephalic vein just above the aortic arch, coming, obviously taking the superior vena cava coming down, brachiocephalic, and that's going to go and it's going to continue into the superior vena cava. And actually from here, you start to see some of your vessels from your three-vessel view in a sagittal plane, because this is the superior vena cava, and then the aorta, and then the pulmonary artery. So I'm doing the sweep, sagittal sweep between the pulmonary artery on the left, into the aorta, and into the superior vena cava here. So there's a different way of looking at all three vessel views. And it's a nice and a smooth aortic arch. This point is where the arterial duct is going to come. So this is the aortic isthmus going down to the descending aorta, for trying to make sure that we don't have any coarctation And as a cardiologist, I always take a view of the sagittal view of the aortic arch. Always need to see the whole aortic arch. I don't use just the sagittal views. So coming back here, I'm not quite sure how much more time. In a baby that you start scanning, you say, oh no, spine on the top. Really, don't be put off by that. We've seen everything. If you're here, it's more difficult, but just go to the side a little bit. And you can see all the structures. Just minor adjustments here that I'm making just to see separate things from 4-chamber, outflow tracts, 3-vessel trachea view, so everything there. Beautiful baby.
Great.
Okay.
You're ready.
I think.
Thank you. I thank Giulini very much, but more the colleagues who accepted to be a volunteer for live scanning. Please, a big applause for her. And now we move to the next patient. Do you have any questions to the live demo? You see, despite a position which is not ideal, you can get step by step to all the structures you wanted to see. One of the messages I could give you with this live demo is that under ideal conditions, you may do one sweep, and you see with this sweep all the structures at the same time. But here you should struggle for in one plane for the left atrium, the other plane for the right atrium, one for the right ventricle. This is why if you have a systematic approach, you will not fail. But if you are looking and waiting that some things happen, you will not be achieving at the end the final diagnosis. In general, it's easier to show you nice images on normal heart, but it's quite challenging to find a rare abnormality and having good images because the fetuses are not waiting for you until you get to the proper picture. On screening, you are limited in time. If you have a high-risk patient, it's easier, but let's say very few are on a high-risk condition, and this is why now Kai is scanning patient 24 weeks. And I can say a few words. This is from Dr. Nauschutz. I think she's sitting somewhere here. Are you still there, Birgit? She left? No, come on. Birgit. She's behind. Okay, so she detected this condition at nuchal screening at 13 weeks. It's in right-sided aortic arc. And we've done the invasive. It's normal. And I saw the lady last week for the second trimester scan, and she was so kind to come to come. So, Kai?
So, can we start?
Yeah, you can.
Okay. So, the fetus is 24 weeks, the lady, and the fetus is in a vertex presentation. And this means the left side is down. We start the fetal echo in the level of the upper abdomen. You see the stomach, you see the aorta, inferior vena cava, umbilical vein, and on the right side the gallbladder. Then we do the switch to the 4-chamber view. It's a 4-chamber view from the side. We have the right ventricle. You see the papillary muscle in the moderator band and the right ventricle going to the apex of the right ventricle. You see the ventricular septum, 90-degree angle. So we have a very good sonographic imaging of the ventricular septum. You see the left ventricular septum. You see both AV valves, tricuspid valve and mitral valve. Okay, the baby is not really cooperative. So we go to the other side. Again, starting in the upper abdomen, stomach, heart. It's the first baby on the day in the same position, so all the babies. So we have a left ventricle, which building the apex of the heart. We have then the 2 AV valves. Then we come to the left ventricular outflow tract, and you see the movement of the valve of the aorta. You saw it. Then we go to the, it's a little bit like a fight. Then we go to the pulmonary trunk. With the course of the right pulmonary artery is left pulmonary artery, the duct, and then you see the aorta is on the right. And we expect the course of the aorta coming from the right, going to the left, but the aorta stays on the right. So we have three vessels, the superior vena cava, the aorta stays on the right as in right aortic arch, and the ductal arch with the course behind the trachea. The trachea is here. This is a U sign. And when I go with a transducer
This is called live demo, not video demo. This is why it should be like
so
live.
in front of the three vessels, we see the thymus, and the three vessels are in the middle between the spine and the sternum. You see the U sign. You see the trachea in between. Normally, we see the ladies again with 28 weeks to exclude a double aortic arch because this is the best time to do this. And then you see a small vessel here in front of the three vessels. This is the innominate or left brachycephalic vein. You will hear in the afternoon about this. It's a very important vein building the background of the thymus.
Can you get again a four-chamber view, Kai, and show where is the descending aorta in the four-chamber view?
So when we go back to the four-chamber view,
Stop.
we have the left ventricle, we have the aorta, this is the spine. This means in the level of the four-chamber view, the aorta is going back to the, maybe I think it's in the middle, it's not really in the left. In the upper abdomen, she is on the left. And when I go up, it is right. So what we search when we look for a double aortic arch is we go in a longitudinal view, and we come from the spine, it's a coronal or frontal view, and we go inside the baby. You see the aorta. It's a problem of the bones, because I search for the trachea, and in cases with double aortic arch, always we have the compression of the trachea, and this is one of the leading signs for double aortic arch, but it's not really good to present.
Try with color now, please.
So with color, we can demonstrate the normal diastolic filling of the ventricles. We can demonstrate the normal antegrade perfusion of the aorta, the normal antegrade perfusion of the pulmonary trunk with a ductal arch, and you see in color also the U sign. When you expect a double aortic arch, you will see a vessel here. Sometimes you will misinterpret this vessel. This is one of the vessels coming from the aorta going to the left. I think it's a left subclavian artery going to the left side, and this is not sign for a double aortic arch. You must exclude this later in pregnancy because you see it goes over the ductal arch to the left side.
Try to get a slightly longitudinal view, and we see if... No, but I mean in color, please, Kai. You are... And a little bit longitudinal, that we see where is this vessel going to. Because then we see that it's going up then rather than joining the left side.
So this is the aortic arch. superior vena cava. And the head and neck vessels arising from the aortic arch. If the baby is maybe in a good position, we can try to use one stick volume. I choose an angle of 30 degrees. I choose the size of the box like the chest. I take the 5-chamber view. I press the button start. During the acquisition process, you will see if all the structures of the heart are inside the fetal box. We have not really fetal movements, it is okay. So 152 beats per minute. First I increased plane A, I reduced the speed that I see all the different structures, and now I perform a vertical examination with the course of the pulmonary trunk, and you see the right ductal arch. Then maybe you search with tomographic ultrasound image, and I changed the distance. You see the 4-chamber view. And you see a normal 4-chamber view here. You see the course of the aorta coming from the left. You see the pulmonary trunk and the right aortic arch. So all the typical features of this malformation we have there. And at the end, I choose for a rendered image. I always go to plane B. I decrease the size of the box, change that I have a background in my box. I always like to have sepia and blue.
I know the text.
You know, Rabbi and me, we are married.
Not so really.
And
even
then,
if it's allowed in Germany, it's not yet that. I have very nice one. But you see now the aorta on the right side.
and then you see the right ventricle, the left ventricle, both atria, and when I do again the virtual examination, you see the course of the aorta coming from the left going to the right. You see the pulmonary trunk, and you see the aorta staying on the right, and you have an impression of the diameter of these vessels. And at the end, maybe you go to minimum mode, and you have an information about the vessels, and you see the ductal arch and the aortic arch.
Can you invert it, Kai, please?
Yes. You see the pulmonary trunk. This is a raw image with the ductal arch, the right pulmonary artery, and the aortic arch stays on the right side.
Okay.
So here we see the trachea. So we change the transducer.
I asked him to try with the linear transducer, then we can see if the baby turns into proper position. No. Try to show us the time is with the
I
high
think
resolution.
you have an imagination, right and left ventricle, and we go up three-vessel trachea view with a innominate or left brachiocephalic vein, and you see the thymus, and you see the difference in the structure of the thymus between thymus and lung.
So I think the baby wants to, this typical postprandial when there is a lot of glucose, they are breathing and moving. So we thank you, Kai, and you can make some pictures for the lady, and we'll continue that we can catch up time. Thanks.